Welcome, everybody, to today's Learn at Lunch session with Dr. Evan Gwilliam. The title of it is Advanced Documentation Training, and you can see on the screen he's got Audit Yourself Before Someone Else Does. And as Dr. Gwilliam and I were talking, documentation isn't the most glamorous topic, and it just seems like we're always having to be discussing it. But I think it is a very relevant topic, and within the last month or so, I've had a number of doctors ask me, the same question of, am I documenting more than I really need to? Am I spending more time documenting the care? I've seen other doctors' notes, I think I do a better job of documentation, and so is it kind of overkill? So I've asked Dr. Gwilliam to come on and go through some information with us. He's a industry-leading expert, I call him, in the area of documentation and knowing what the payers around the country are expecting from providers as far as documentation, coding, and billing. And so I'm glad to have him with us today. We do want to make this interactive. We'd like it to be as though we're just sitting in a room and he's in front of us talking and have interactions. So please, I know you're all muted, but if you have any questions as he's going through the material, feel free to unmute yourself and hop in and ask him any question, or make any comments that you have. So this is being recorded. We will be providing a 6-question test for you to get your CE credit afterwards. So you'll be getting an email with that probably later today. So with that, I'm going to turn it over. Take it away, Evan.
All right, thanks a lot, Jeff. This is fun. I'm excited to be here. This is different than what I normally get to do because this is interactive. This is training. So I'm curious to see what you guys have to say about the things I'm sharing with you. And I do want you, as Jeff said, to treat this as if we're sitting in a room together. This is a bit random as well. I've got a lot of stuff in here based on things that Jeff specifically requested me to talk about based on his feedback from you guys. And I got to look at some of those audits that you did of each other. And so I'm trying to include what I think is the most helpful to you. I don't want you to see documentation as some big administrative burden. I want you to see it as just a piece of doing business and something you can systematize and make simpler so that it's just something you can get done and get out of the way. I think it's a bit like learning a foreign language, right? You got to study it a lot at first, but eventually you become fluent and it's just what you do. It's second nature. And so I'm hoping that I can teach you some things that will make it so the documentation is not something you feel like you do too much of or have to spend too much time on, but it's just second nature and you do it and get it done and move on. I had a client, at a seminar, actually, it was an audience member, and she came up to me after I taught, and she said, "Look, you're telling me I gotta have these, great records that include changes, and there's a care plan that I follow, and there's stages, and the diagnoses are documented correctly. And that's a lot of work. I want to see 100 patients a day, 500 patients a week. I want to have a high volume practice, and I want to grow from there. I want to go even farther. How do I do that?" And I said, "Well, at some point, there's a trade-off. You're going to either have to streamline so much that you can manage it. You're going to have to hire more staff and delegate. At some point, you can't do all that you need to remain compliant and expand exponentially. There is a limit. There's a balance somewhere." Excuse me. I want you to think of it like a speed limit. You guys have to decide what your tolerance is. You don't have to do everything I'm going to tell you right now. You could do none of it, but you're going to have higher risk. You can do everything I share with you, and you'll have lesser risk. So you need to understand that it's up to you. If you want to go 5 miles over the speed limit, that's not too risky. Yeah, you probably can pull over. But if you're going 50 over the speed limit, you're gonna pop up. They're gonna see you, and they're gonna pull you over. So I want you to kind of see it that way. Take the things I share with you today and go, that one I can do. That one, no way. This one works. And maybe we'll discuss it, and you'll say, you know what? That's it. I like what he's saying, but how about this? And we can discuss it and suggest things and make it easier for you, okay? So I call it audit yourself before someone else does, because I want you to understand what a third party wants to see and want me to look at it. As Jeff said, I've got a bunch of credentials, and just know that I know what I'm doing. I'm here to help you guys, okay? You can read over that stuff, but I know what I'm talking about. So this is kind of my goal here. I want you to treat the third parties, the payers, the claims reviewer, the auditor, as if they are somebody who you really want to impress, and you're handing them over this gift. And you have this gift, and you want it to be the perfect gift, the one that they want. So my goal is to share with you what that gift is and what exactly it is they're asking for. Okay, so that we can present them with a the thing that's going to make our relationship easier and smoother and everybody happy.
Still on sale for $319.
So as you're looking here at my screen, I just want to show you a couple things before I get into some of the content. This is a sample of an audit report that I create for my clients. You can see that this person got a C+ on my grading scale. And I'm getting a lot of echo all of a sudden. If everybody, unless you have something you want to jump in and say, keep yourself muted if you could. There you go, that's a little better. So I just wanted you to see one way to look at this. This isn't necessarily the system used by outsiders, but it's what I use. And if you look at the bottom of this, there's a summary of how I scored this patient, this client's record. They did okay on the well, like their initial evaluation, they got a D, pretty lousy. The reevaluations, they got a B+. And so I went through and I evaluated all those elements. Here's an example of a detailed part of this report. This is when I audited their chiropractic manipulative treatment. And I came up with a point value, and I marked whether the items were present, deficient, or absent. And then I specified if it was deficient or absent, what they need to do to improve that. So we're going to talk about some of this stuff today, but I just wanted you to see a sample of one way you could look at an audit and how it could be performed. And so this is just a tool that I've devised for my own usage, but it's similar to what you guys have done with Jeff in those internal audits that you've done with each other. Now, as I mentioned, I've got some kind of a mismatch of stuff in here because I don't have an outline for you where I'm going to do this, this, and this. I've got 4 different topics just kind of scattered throughout here, and I want to hit each one and talk about it until you feel comfortable with it and move on to the next one. Okay? So this first one is very important for you to understand, and this is a draft of Medicare's potential updates for your state. This is from Noridian, and this is what they're saying they want. It's a change that they're proposing that we expect to be kicked in any time. In a lot of other parts of the country, other Medicare contractors have already adopted this change, but this is one that last year sometime Noridian said they'll probably do it, but they haven't actually done it yet. We're kind of not really sure why. We're just waiting to see. So what you're looking at here is from the Medicare LCD from Meridian. It says that this is how they want you to document a subsequent visit. And previously, this had 3 things in it. It had numbers 1, 2, and 3, as you see in the list. But they added some commentary to number 2, and they added number 4. So let me just talk about each of those. Number 4 is documentation of how the day's treatment fits within the plan of care. For example, visit 4 of plan 7 treatments. In other words, you need to specify at every visit what visit number it is within a care plan. Right? That's what payers are expecting to see. And even though it's not official, I would suggest you just do it. For all payers, no matter who they are. This is a Medicare policy, but it's just a good idea. And the reason is it helps convey this concept of the episode of care. And the episode of care is this view of the entire case from beginning to end. Payers like to see that there was a problem, and the patient showed up for the problem, you put together a plan to fix it, and you worked on it, and then at the end, the plan was resolved. Then it's an episode. And that's what they expect to see, that's what they want to see, and that's how you can convey to them something that's medically necessary. If you're sitting here going, you know what, I don't treat patients like that. I have patients who come in and go as they please. I've seen them once or twice. I don't see them again for a couple months. That's just my model. You're okay having that model, but you're not okay trying to communicate that to third parties. They're looking for this, all right? They're looking for an episode of care. They expect to see something more structured where a classic patient gets hurt, has a problem, you fix it, it ends. That's what they think is happening, not this kind of chronic in and out. So if you have this chronic stuff, a couple of visits here and there, and there's no care plans in place and so on, you have the power to do that, but I'm letting you know that's not really the way the healthcare reimbursement world looks at chiropractic as reimbursable anyway. So just understand that, and that's just if you choose to treat that way, don't expect to get reimbursed as much for it or as often. It may be a lot of cash-based services. The other thing I want to mention in this episode of care, and I'll open up for comments if you want in a minute, is number 2, the physical exam. That's always been there, but they added that a full repeat of PART is not expected. I'm going to talk about this later on in our little training today. I really don't like that rule. I think that a full repeat of PART should be done every visit that you do an adjustment, and I'll explain more why later. It was explained to me the reason that this got worked into this update, this draft of the Medicare guidelines, is because they're trying to make it so chiropractors don't have to do as much that's required. In other words, they have the clinical ability to decide themselves. And so they can decide whether or not they want to document part on that visit. The reason I believe you should document every visit is because I think part is the best way to support an M990 diagnosis. And I believe that an M990 diagnosis is the best way to justify a chiropractic manipulation. So I think it'd be great if every visit where you did a chiropractic manipulation, you clearly and distinctly outlined the part model to show that a subluxation exists. And I'm a little concerned about someone saying, well, I didn't do part because it wasn't expected. But then at that particular encounter, there's no evidence that the patient needed to be adjusted. So I don't like this particular rule. It's there though, so take it for what it's worth. But that's just my take on it. Okay, so those are some changes you need to be aware of from Medicare that may become official sooner or later. They may not, and even if they don't, you should probably do number 4 anyway, put the visit number in. But I would ignore the change to number 2 and keep doing part, because you can still do it. There's no consequence for doing it. And I think it's fast and easy and a good way to support your care. So some of you may have seen me present other times where I talk about the episode of care like this as a journey. I just want to summarize it real quick, just to kind of bring this together. And then I'll pause for a moment, see if you guys have any comments or questions. In the upper left, we have an initial evaluation. In the lower right, we have a discharge evaluation. And in between, we have a bunch of treatment visits and possibly an interim evaluation in there. And so payers expect to see cases that look like this, where there is an initial visit and then there's a journey, a plan to get somewhere, a destination. And in between, there's treatments or there's directions, there's things that happen that are carried out. And maybe in the middle, there's a waypoint or a pause where you decide whether or not you're going to continue onward or change direction. And hopefully you still can make it to the end. So they want to see these kinds of evaluations to determine if the care is going the way they expect and if everybody is seeing what they want to see. So let me pause here for a moment and see if there's anyone who wants to chime in or has any questions for me before I sort of shift away from this episode of care. This is sort of overrides everything, and we'll come back to it, but I just wanted to introduce it before I get into some heavier stuff. Does anyone have anything they want to add or any concerns or comments you want to share with the group? Okay, if you're not fast enough, I'll just move on. So, episode of care, it's just a big picture kind of thing I want you to be aware of. Now, I want to dive in a little bit and talk about specifically the daily visits. Let me go back again. In this map, there are these the T. These are the treatment visits, right? This is a typical encounter in between the evaluations where I just treat a patient. So I want to talk to you about the specific requirements for these visits and how to document them and what needs to be included. And I have here in the next few slides requirements from 3 or 4 different sources, just so you can see how they fit together and even contradict each other a little bit in a few circumstances. This first screen shows you Optum's requirements for daily visits. Optum is the group that oversees United Healthcare. So a lot of you probably work with them. They say, look, we need 4 things in a daily visit. We need a subjective record of the patient complaint, including these details. We need physical findings that supports that manipulation was necessary. And they give examples of how that can be supported. If you look closely at this, it looks a whole lot like PART, which is Medicare's requirements. Number 3 says they want an assessment of change in the patient's condition. And I'm going to put the word change, I wish I'd done this in bold, in quotes, underlined, because I think change is a really critical part of daily visits. As much as you can capture it, it's very important to convey it. The more you have, the better your case is. And then number 4, they want a list of all the segments that were manipulated, which, so this is what Optum says they want to see. So you might look at this and go, okay, if I have a patient who has United Healthcare or Optum, I better make sure that I label it with these 4 things, right? And maybe that's not so bad, but then, let's say you're in Colorado. This is just an example. Actually, I should have found out if your state has their own specific rules, but Colorado has this thing called Rule 22. And they specifically outline for chiropractors what should be included in an established patient visit. And they say there are 5 things. You can see them listed here. A subjective complaint, objective findings, an assessment or a diagnosis. And it says that doesn't have to be updated every time, because that may not change, but certainly at reevaluations. And then there's a plan that they want to see that explains what's going to happen based on the diagnosis. And you see the word change down there again in that paragraph about plans. And then we have the procedures, a list of what was done that day. Right? And time should be part of that for the time-based codes. So, this is a little different from Optum. There's 5 things here instead of 4, but you can see a lot of overlap, a lot of similarities, right? So let's move on. So that's a state board requirement. We had a private payer, now we have a state board. Let's go on. This is a provider network that I've done some work for in the Midwest. And they have me train some of their doctors on their panel. And they, when they did that, they sent me some information, said, here's what we expect our providers to include in daily visits as we do reviews for them. And they came up with 9 things. Okay, so here's the first 4. This is a little bit more specific. They said we want the patient ID, date of birth, the date of the encounter. They want the visit number, okay, just like Medicare does. Notice that Optum didn't say they wanted a visit number, and neither did Colorado for their state board. But here, this payer does. They want a chief complaint. They want updated patient-specific measurable, subjective, and objective attributes. That is a loaded phrase right there, but there's some really good stuff in that. And then they said number 5, they want an assessment of changes. Again, we focus on change that are specific to that patient. They want to know the diagnosis. They want to know the procedures that are performed. They want a plan, including the day of the next treatment and the next reeval. So the next treatment might be Thursday. The next reeval might be in 2 weeks. They want all that. And then, of course, at the end, they want a signature with the date and timestamp. And just so you know, the date and timestamp is sort of a gray area. Is it required by everybody? Not necessarily, but it sure is a good idea. So it's another example of some good stuff. So you might look at this and go, shoot, if I'm part of this network, I got to come up with a note that has 9 things on it, right? But if I had Optum, I got that patient, I only need 4. And if I was Colorado, I need 5, and I got to figure all this stuff out. And, what about our classic friend SOAP note? Like, how does that tie into all this? So here's what I want to do with you over the next few minutes. I would like to present to you a way to use the SOAP note as the way that you provide information for a daily visit, and it satisfies all of those guys: Medicare, Optum, Colorado State Boards, and an insurance panel as examples of sources who said what they want. I want to simplify it for you. I want you to be able to administer this in a way that doesn't slow you down, and you don't have to treat every patient differently and meet certain requirements. Instead, we come with kind of a universal approach, the universal SOAP note, I'll call it, that satisfies all the payers. And forget the payers for a minute, it satisfies you. It does what you want. It captures the information you think you need. It's helpful in your records. And if you were to give me or Jeff or somebody your records and said, look them over, tell me what you think, that if you follow this layout, this format, it would capture everything and satisfy anybody. Right? That's what I'm trying to do. And it's not perfect. There's a few flaws in here. It's not ideal, but I got pretty close, I think. And so I really want you guys to chime in and tell me if you disagree or if there's ideas you have on how to improve this. But I think I've captured most of what needs to happen, all right, in a typical visit. So we're going to go through this. I'll pause for a moment again before I dive in. Does anyone want to chime in for a moment? Have any comments or questions before I start dissecting this? Okay, so I have to pause from time to time because when I present, I've been told that I got feedback once that said that I like to hear myself talk. So I worry sometimes that I'm too busy listening to myself and I don't notice other people want to say things. So feel free, again, to interrupt me if you feel the need. You'll notice that for SOAP here, I've got subjective, objective assessment, and plan, and I added procedures as another P. And so you'll see some sources actually do SOAP with 2 Ps on it because it originally was just plan, but it makes sense to put procedures in there as well because it's a place to capture that information, and it still starts with a P, so it fits the acronym. So let's work our way through this a little bit. Before we do, though, I want to talk about cloned records. Cloning is a real problem, and some of you say, well, the way I'm going to make great notes is I'll just come up with all these great phrases and I'll use them over and over again. This is an example. These tables I got are from Noridian. I think it was about 5 years ago. They came out with one of their little articles or whatever that gave these examples, and they said, we don't like cloned records. We are aware of them. They bother us, and we don't want them to. We don't want chiropractors to clone their records. And they gave examples here so we could see what they see, what they know is a clone. So if you look at the first one there, day 1 under subjective, it says, the patient is troubled by a moderate grade of intermittent dull pain with stiffness, soreness in her head on both sides. And that sounds fine, but if you read day 2 and day 3, they say the exact same things. There's nothing that's any different except the words are in different locations. Or maybe they changed from both sides to the word bilateral. They move the words around. Troubled got switched out with afflicted. So I'm warning you that the payers know when you just change words, so the goal for changes to be documented isn't to change the words. The goal is to record changes in their condition, subjective and objective. And I'm going to give you some tips here in a little bit on how to do that better, to make sure that your subjective information doesn't look cloned every time, and you record and capture objective changes as much as possible. Because at the end of the day, for daily visits, treatment visits, the only thing that really matters, not the only thing, but the thing that matters the most in those visits is the changes. I don't necessarily need you to repeat to me their chief complaint over and over and just give me that every daily visit at the subjective. I want to know what changed in their chief complaint. That's what matters. Okay, so that's what the focus has to be on. So you can see these examples. But rather than read them to you, here's some tips for how you avoid clones, okay? How you stop from looking like you clone your records. Beware of text spinners or random text generators. If your software does that, that's a problem. And I would, well, if your software does that, you need to go in and customize your notes some and go beyond it because this won't fly. The payers are aware of what that looks like. So here's some things you can do to avoid cloning. You can quote your patient. This is actually my favorite solution. When you have a patient who comes in and they say, man, I just couldn't sleep last night. It was so bad. You know, my neck was killing me. That's perfect. Put that in quotes and put it in the note because anything in quotes is never going to be the exact same. What they say today won't be the same as what they said a week ago, or it won't be the same word for word. So it'll make the notes, it'll show that there's differences and the notes have changed and adapted. And I would encourage you to ask the patient about an activity of daily living at every visit. So let's say they did an Oswestry questionnaire and they had problems with lifting and walking and sleeping. Well, then, not every visit, but frequently, ask them about one of those three things, if not all of them, and just say, hey, how's your sleep changed since the last visit? Have you found that you can walk further or less distance? What's going on with the pain there? And then you get them in quotes saying, you know what, I can walk about a block further before the pain gets me. Perfect. Put that in quotes, put it in there. It shows functional gains. It shows that the record is not cloned, and it shows that it's patient-centered and specific because it's their words. And no other note's going to have those same words in it. So that's one of my bits of advice. Another one is when you put together the care plan, consider the patient's age, the severity of the condition, the complicating factors, because an 8-year-old that's healthy and has a minor neck problem is going to have a very different care plan from an 80-year-old who was in a severe car accident and has diabetes. Like those care plans should not be identical. You can also mention specific goals that have actual numbers in them, not just I want to improve their range of motion or improve their OATS score, but you actually put the range of motion or the OATS score in the note because those numbers are only going to apply to that particular patient at that time. And that'll make the note unique. Also, the diagnoses aren't going to be the same for everybody. If you do pain and subluxations or only diagnoses, I got to warn you, that's like speeding. That's like speeding in a school zone. Those diagnoses are pretty weak and they don't tell enough of the story. Your goal as a clinician is to provide an explanation for the pain. And so you can say there's a subluxation contributing, but then you want to come up with a condition. And if you can provide a condition, payers are more likely to recognize medical necessity. And then changes, really, really critical. Just focus on changes. Reviewers want to see what changed from visit to visit. Not so much what's the same as last visit. That's not as important as what's changed. Okay, so those are my tips for you on how to keep from being cloned. This is how a record looks in my software. So I am the clinical director for PayDC, which is a chiropractic EHR, cloud-based system. And this is currently how our notes look. I just want to point out that the bold. We have a feature where if something changed from one visit to the next, we bold it for you so the auditor can see exactly what we're looking for. So I would encourage you, however your records are, to make it easy for the auditor to see the changes. And if you have a feature like this, use it. If you don't, think about a way that maybe you can implement a way to focus on the changes from one visit to the next so that third parties can see those changes easily and at a glance, like in this note. Okay, and you can see we have the visit number up there as well. So that's just an example. So back to soap notes here. And I'll pause one more time. Does anyone have anything you want to add or any questions about cloning in that particular problem? It's a major issue, and it's something that payers are aware of, and they get on, and they're doing their best to catch it, I should say. I'll tell you one of the secrets I use when I audit. If someone sends me paper records, I'm doing an audit. I will take the records, and I'll get 2 pages, and I'll hold them up like this over each other, and I'll hold it up to the light. And if I can see the same letters in that, if the first letter of every line lines up and it's the exact same letter and the whole page long, that's cloned. It's just cloned. I don't even have to look at the rest of the note. I just know it's the same as the last one. So we want to minimize that. The subjective portion of the note. This is preferably in the patient's own words. So I often see notes where it says intermittent low back pain rated 6 out of 10. And that's the subjective portion. And that is useful information, but I want to know what's different from the time before. And I want to know if the patient says something about their ADLs in there. I really want that information. So in the subjective, I'd like you to put in something quoted by the patient, and then you can list the complaints and update what they are by location. So if they have neck and low back, I want to know the region, the severity, the character, the duration, and timing, and the aggravating or relieving factors. This is kind of your HPI or OPQRST. But really, I want you to emphasize change since the last visit. And here's an example. They're in brown on your screen. I can walk a few hundred yards further before the pain stops me. Or I can sleep 3 hours before the pain wakes me up. In quotes, that's a great way to show your records aren't cloned, and it's very useful information, again, for showing functional gains, avoiding cloning, establishing medical necessity. It's a good way to do it. Now, if you copy and paste on more than a couple of visits, it looks like cloning. So I know that sometimes things don't change for a couple of visits. I know some of you are thinking that right now. Well, sometimes it just is, it's been 2 days, there's not much change. It's been even a week, sometimes not a lot of change. I'm just letting you know that if you have a patient and you've seen them, let's say 5 times, and there's been no change in the subjective information, if I work for United Healthcare and I was trying to deny payment, I would simply say, I don't see enough change. We pay you to get the patient better, and if they're the same for 5 visits in a row, then we'll only pay for the first couple visits because you didn't get anything, you didn't get any results. So just be aware that that's how the payers are seeing your records, and it's your job to show them that your work brings about improvements and change. And if they don't bring about improvement and change, that you stopped and you either changed care, you referred the patient out, you acknowledged it and did something different to try to address the issue. So I created an example here of a subjective note that kind of captures most of what I put in there. It says, Mary Jane presents today for continued left-sided, dull, achy neck pain that began last week after sleeping wrong. She states something, so I put in quotes. She states the pain has improved from 6 to 4 since the last visit. So I got a change in there too. So that's all I've got in there, and that's sufficient. It's not perfect, but it's pretty good. I think that would satisfy most. So then move to the objective, okay? And instead of being information the patient provides, this is information that the provider is able to elicit through their observation. It's quantifiable. Ideally, it's numerical. The best objective findings are the ones with numbers on them. Numbers are easier to agree upon and harder to refute, and they're much more cold than objective. So we like quantifiable information. So this is where I would include information about PART. I believe that this is a great way to document that a subluxation or segmental dysfunction exists by using Medicare's model of PART. And for those of you who don't know, there's 4 parts to that: pain, asymmetry, range of motion, and tenderness, tissue, tone changes. Sorry, not tenderness, but tissue and tone changes. So you have to do 2 of the 4, and one of the 2 has to be A or R. Anyway, that's another discussion. I think we might talk about that here. But now that just satisfies the justification for the chiropractic manipulation. What about other diagnoses? Maybe they have radiculopathy, or they have some muscle spasms or something. I believe that that's sort of separate. You can overlap these, but I like to distinguish them and separate them out and say, okay, here's some other findings that I can use to support other diagnoses I have in the objective portion. Palpation, range of motion, stability, muscle strength and tone. And that's from the 1997 documentation guidelines for the musculoskeletal exam. Now, some of you might look at that and go, well, how's that different from PART? And you know what? It's actually very similar. There's some overlap there. The difference is that PART is a designation that was designed to justify the chiropractic manipulation through the establishment of a subluxation. And then these other 4 things, palpation, range of motion, stability, muscle strength, and tone, have nothing to do with chiropractic. They are what is considered part of a musculoskeletal exam from the general guidelines from 1997. So I suggest it may be useful to even separate those 2 things out to make it easier for an outsider who doesn't know our profession to find what they're looking for. This is also where you can retest orthoneuros, outcome assessment questionnaires if they apply to this visit. But it's all about emphasizing change. And if you do this the same on every visit, so if every single visit I look at, you give me 10 visits, and they all say tight image of muscle fibers at C3 on the right, every single one of them. My argument to you would be, why were you working on that? You didn't get any results. After 10 visits, it's still the exact same findings. I don't think I should pay you for the last 6 of those visits. You can pay for 3 or 4, but that's it. So be aware of that. You need to show some changes. And if you can't bring about changes, or if you feel like those segments are really the same all the time, just understand that payers may choose not to pay you for it. Okay. So here's an example of some objective quantifiable information. I've got involuntary muscle contraction, which satisfies the T in PART, is palpated on the right side from C3 to C7 with tenderness, which satisfies the P in PART, and restricted left rotation lateral bending. And then I've got a change in here. Right lateral bending is no longer restricted, so I put in a change to show progress. All other sectional range of motion within normal limits, and then we have restricted intersegmental motion at certain specific levels. So, and I labeled it with the R to show that that's part of the PART. So this is pretty simple. It's a narrative format. I actually prefer more of a bullet list approach to this to daily notes. And we're working in our software to change how our narrative looks right now. But I'm not as big a fan as a paragraph because it's harder to audit and harder to find what you're looking for. But lists and tables make things easier. So that brings us to the A, or the assessment.
Evan, this is Jeff. Could you go back to the previous slide? You know, I've had doctors ask about, you know, how much information do they need to provide about range of motion? You know, do you have to do specific degrees? Whatever. Can you speak to that a little bit?
So that's right. I'm not aware of any Medicare guideline that says you must specify the actual degrees. Having said that, the more information you can provide, the better. I mean, if you want to err on the side of caution, if you want to go the speed limit, right? If we're talking about compliance, and you want to stay under the radar, and you want to be, you know, you don't want to get pulled over in a school zone, actual degrees is better. A couple of observations on degrees. If you visualize it, if you just look at the patient and you say, okay, you know, tip your head down, tip it back, and I say, well, that looks like about 70 degrees, and that's, you know, whatever it is, 60. I would suggest your wording is estimated range of motion. That you say, I estimated the range of motion, I visualized the range of motion, here's what it is. But if you have instruments with a computer, that's when you actually put real degrees. I've been in a couple of cases where doctors have gotten in trouble for visualizing range of motion, but implying that it was exact. And so if you visualize range of motion, call it estimated or visualized, just to clarify that. I don't believe that you're required to specify that. I think it may be sufficient to say, you know, it's the range of motion is moderately decreased or severely decreased. But it'd be better off if you give more detail. So again, I'm not aware of a specific requirement to get that detailed, but if you're so inclined, I don't think it would hurt you to do so. And I think, well, the way I worded it here was it's improved, I think is what I said. Lateral bending is no longer restricted. So I was kind of vague in this one. See, I don't have a concrete answer for you, but I hope that helps you kind of see how, as far as I know, that's how I would look at it. Any other comments on that, Jeff, or concerns? I don't think I really answered it, but, you know.
One other question. With your muscle spasm or involuntary contraction, do you ever grade that 1 to 4?
So not with muscle spasm, but correct me if I'm wrong, I'm not a clinical expert, I'm a documentation expert, but I'm not sure that there's a scale assigned to spasms that's you know, like there's one for muscle strength that's called the Oxford scale, right? So there are some official ones out there, but I'm not aware of one for quantifying. Now, I don't see why you couldn't quantify it yourself, though. I think that would be acceptable. As long as there's not, is there a standard?
Well, I don't think there's a standard necessarily, but there are some sources that give you, you know, 0 to 4.
Here's the thing I like. I mean, you could easily put, let's say we did 0 to 10. You could say, and they've got some severe muscle spasms, and you put in there 8 out of 10, then it's your own rating scale, and I think you have the prerogative to create that. Think about this, the bigger the scale you have, the more space you have to document changes. So if you did 0 to 4, that's fine, but you only have 5 increments to move, you know, from 0 to 4. But if you did 0 to 10 and you made your own scale, you could go from 8 to 7 one visit. And maybe someone could argue, well, are you really that sensitive? Can you tell? But, you know, I think it gives you an opportunity to convey changes if you have a larger scale. That's why I prefer not to say mild, moderate, severe, because they only have 3 options. I prefer to put things on a numeric scale. And if you put it out of 10, then it's your own scale, and it's okay. It's fine, unless there's a standard, like I said, for muscle strength, for example, or for reflexes. You know, those have set scales, but that's what I would advise there. Right? Any other questions about objective? All right, so let's look at the assessment. Here's how I view what an assessment is. I take my subjective findings from the patient. I take the objective findings I gathered when I did my evaluation. I dump them into a bucket, and I stir it around, and I look in there, and I go, what have I got? And I come up with an assessment. So that's why I have here S plus O equals A. The assessment is my conclusion, where I describe what I found. Now, this needs to be much more thorough at the initial evaluation. And I showed you one of those guidelines. One of them said, you know, we don't expect you to update a full assessment at every daily visit. We get that that's kind of what it is. But if something changes or there's something that needs to be updated, you can do that. It certainly is more critical at the reevaluations or the initial evaluation. Regardless, it's a good place to capture a diagnostic statement or a clinical impression, where you say, here's what's wrong with the patient, right? And I think at a minimum, you should include a list of your diagnosis codes in a daily visit, In fact, Noridian did come out several years ago and say they like to see a list of the diagnosis codes at every visit, but they don't require it. But they like to see it. They worded something like that. So I would strongly encourage you to do that. This is where you can also comment on the subjective progress. So, back in the subjective, you quoted the patient as saying that they sleep better. Here in the assessment, you're the assessor. You could say, and it looks like we're getting closer to our goal of 8 hours of sleep because they seem to be doing a little better. You could take a moment to say that at a daily visit, and it shows changes in progress. Same thing with objective findings. You might have said during the objective, there's no longer restriction in left lateral bending. And then in the assessment, you could take a moment and say, hey, it looks like the range of motion is getting better. And we had a goal to get that better. So you could take a moment to say that if it was relevant. This is also where you comment on patient compliance or lack thereof. Well, the patient's gone on vacation for 3 weeks, haven't seen him. This is where you can talk about barriers to recovery, such as diabetes or pregnancy, or their work that they do. They work in a manual labor thing, other aggravating factors. And this, you can also put this in plan. I've kind of debated whether this belongs to this, but progress towards short and long-term goals. So a feature we're just adding to our software is we're putting a little space where you can list the long-term goals you established at the beginning of the care plan on the side. And if you want to, at a daily visit, you can say, we're 50% towards accomplishing that goal, or 80% towards accomplishing that goal. So you can comment on your progress. This is something PTs have done for a long time, and some PT software I've looked at. They include the goals at every visit, and at every visit they're required to rate what percentage they are of completion towards that goal. So ideally, if you had a goal to get somewhere in 10 visits, then every visit would be 10% closer to completing your goal. Right? And that really clearly shows changes from visit to visit, and it's something you should consider doing if you find that it fits the way that you practice and the types of goals you set. And this is also where you can mention the phase of care that you're in. If you set up stages of care, which I advise you to do, you can say, we're in the first phase of care, which is relief. And your first phase of care may have slightly different goals and treatment parameters than your second phase of care or stage of care. And so I'm a big fan of stages because they provide benchmarks periodically. And I think a stage of care should last no more than 4 weeks. I shouldn't say no more, but 4 weeks is a good average. So you do a relief phase of care for 4 weeks, and you have certain goals. And when you hit that, you do a reevaluation. You say, okay, we kind of accomplished most of those goals. Here's some new goals, and we're in a new phase of care. We call it the corrective phase. And I think that's a great thing to convey in the assessment. That was all set up back in the initial visit, though. So here's an example of an assessment. I just some diagnoses here. Not great diagnoses, but I listed some. And then I've got some statements here that says the patient's progressing well as evidenced by. Here's a tip for you. Here's a golden nugget from this. If you say the patient's doing well, or they're progressing well, or they're doing slow, or whatever, I want you to add the phrase as evidenced by, and then finish the sentence. As a clinician, I think it's your responsibility to document what that is. So what's the evidence you have for that? And so I put in here decreased pain, improvement in sleep, which the original goal was 6 hours. I put the change in the range of motion was a little bit better. Treatment was tolerated without incident, so I got that for medical legal reasons. Short-term goals previously outlined are still expected to be achieved by the next evaluation, and as such, care should follow the plan that we had dated previously. I don't restate the whole plan. I don't put in there the settings for the Easton machine and that. I put that in the care plan, but I don't need to repeat it all the time. I just say as per care plan. So that's my example of an assessment, a daily visit that shows some changes and some stuff going on that shows that it's not just a copy paste from the last visit. And that brings me to the final one, which is the P, which is plan and procedures. So again, you see some references that say the SOAP doesn't necessarily include procedures, but I put them in here because I think it makes sense. And I've got really 4 types of procedures chiros do: CMT, modalities, DME, and therapy. And so then I've got some details for each one. So this is where you can say, today we did chiropractic manipulative treatment, and we adjusted C2 and T4 and 5 and the sacrum, and we used diversified technique. Like that information should be in daily visits. I want you to think of your daily visits as like a script for a play. I want you to be able to hand your notes over to a director who can hire some actors, and they have enough information in there to reenact the encounter. So when you ask how much work is too much work, how much documentation is too much, if you feel confident that your notes could be used to reenact the encounter without you there to explain what's in there, those notes are good enough. I mean, that's kind of the threshold. And if you don't want to go that far, then don't go that far. But I'm letting you know that's a good measure for you to consider if you want to be able to prove that your notes are, at the bar or above. So for things like modalities and therapies, I want some details there. And a daily visit, in order for me to reenact the encounter based on your notes, I need to know what kind of modality it was, where you put it, how long you did it, and why you did it. Those are good things to have reviewed at the daily visit. And then I've got percentage of completion towards specific and measurable goals, kind of repeated here. I had an A. I'm still debating where that belongs, where that fits better. And then this is where you can include home instructions. Even if you've given them previously, you just state that they can, check with the patient, they're still doing the stretches. Good enough. And then this is where you put in the visit number and anticipated date of the next evaluation and the next appointment as well. So this is visit 3 of 7. We're going to reeval at visit 7, something like that. So here's what that might look like in an example. The following services were provided. So I have 2 services there, and for each service I've listed a description of it, the location, the time, and the rationale. And then I have short-term goals towards the bottom there. And for those goals, I've listed their percentage of completion, to outline how close I am to finishing those goals. And then at the bottom, I've said the patient's going to continue the care plan as outlined, including the stretches that we taught previously. So I talked about home care. This is visit 4 of 10. She's going to return in 2 days. The next reevaluation is in 2 weeks. So I've got all the information captured here under the plan, or at least most of it. So I think this note's pretty good. So I'm going to take this back to what Medicare requires and try to tie it together. But let me pause again and see if anyone wants to comment or have questions about what I've shared with you so far. Anyone? Okay. So I take that to mean that everything I've shared with you is perfect and you all agree 100%, which is always good. That's why I like muting on webinars, because then I just assume everybody agrees with me. So as a reminder, we're looking here at the episode of care, and I've got highlighted again the thing that's kind of new, this idea of where does your care fit within an episode, within a plan, within a road trip, a journey from with an origin and a destination. Payers need to see that. If you convey that, you're in much better shape. So Medicare, if you look at those 4 things they require at a daily visit, here they are kind of summarized. And I want to tie them together for you into a SOAP note. Because I don't want you to treat patients differently. I want a Medicare patient to have the same records, the same quality of records as a cash patient, as a PI patient, as a major medical. I want them all to have the same sort of note and format and just try to satisfy all of them at once. Understanding that for a few of you might be doing a little too much, and so others, you just got to come up with a good, solid standard. So if you look at the 4 things here in black, it says history, physical exam, treatment given, and fit within the plan. But let me go back a slide. That's what's listed here in Medicare's requirements. Those are the 4 things they expect to see in a typical daily visit. As a reminder, again, this is a draft. So for Meridian, it's not official that you need all 4 of these. There's only the first 3 actually currently, but just do all 4, okay? Just make the transition. Either they're going to make it official, and even if they don't, it's a good idea to do it this way. So here's the 4 things again, kind of in my own words. And the idea is I tried to fit it into a SOAP note because, interestingly, Medicare, as far as I can tell, has never said anything about SOAP notes. There's nothing under Medicare that says, chiropractors use SOAP note formats so I've gone to the trouble to try to figure out how does the Medicare requirements fit within a SOAP note, and this is how I think it fits. I think what Medicare calls a history fits in the S in a SOAP note. What Medicare calls a physical exam satisfies the O and the A in a SOAP note, the objective and the assessment. And then the P is what Medicare calls the treatment given and the fit within the plan, the episode of care. So that's how I believe they all mesh together. And so this is sort of my template for what you might use as a baseline for a nice SOAP note if you were to do it on paper, right? I think a SOAP note should include all these things. And you guys, Jeff, you're gonna give them access to these slides when we're done. I think you are. People always ask if they can have a copy of this or whatever. It's just in the slides. So you can look at it and decide if you agree or disagree. So you are going to share PDF or something of the slides, Jeff?
Yes, I will.
Okay. So if you guys want to look at this more closely and try to decide if your notes have these elements in it, you could use this as sort of a little audit tool to look at that and see if they're all there. I'm not going to go so far as to say all of these are absolute and they all must be there, but I'm going to say that something that contains all of this will be pretty good. All right. So that's kind of my, and this is just me summarizing everything I shared in the last 10 slides. Okay. So looking at this, does anyone have any comments or questions on it? Anything that you disagree with? You want to fight? All right, no fighters. I like to say when I do presentations, I almost always have someone in the background that I call Statler and Waldorf. If any of you are fans of the Muppets, Statler and Waldorf are the guys that are always sitting up in the balcony. These are 2 old guys and always making fun of the speakers and always complaining about everything. So whenever I go to a live seminar, I always have a Statler and Waldorf in the back, and I'm waiting for one of you to play that role so you can get out there and say, you're all wrong, or I hate this stuff. Because Some people see this and go, that's just a lot of work. I just don't want to do all this work. I just want to take care of my patients and get home at the end of the day and be able to be with my family and pay my bills. And so, and really, this is my intention, is to give you guys something to systematize it, simplify it so that you can do that very thing. I want you to be able to get your work done and leave it behind and know that it's been done properly and not worry about it, not lose sleep over it. Go back and make sure you're getting paid and get audited and not be afraid of an audit. Let them audit you. They want to audit you, and they will, by the way. They're all going to audit you at some point. You go, I've got good stuff. I'm not worried about it. I'm gonna let them take a look, and I'm gonna sleep well knowing that there's somebody pouring over my records right now. So I want to take the few moments we have and talk a bit about care plans specifically, because there's a few elements here that I think are really important for you to understand in terms of third parties and what they're seeing and what they want to know about. Care plans are requirements from certain payers. Care plans are also required by many board of examiners for state boards. Insurance carriers require it. Patients demand it. Patients deserve to know what's going on. They deserve to know what you're planning to do with them instead of just saying, keep coming back. I'm not going to tell you why we're doing what we're doing. And it really shows that you have put together your brain power to decide what to do. And that's what you get paid to do. You get paid as a doctor if you have to use your doctor brain and you went to all that school. And so it's a way for you to capture that and show what you're doing. So what makes a good care plan? How about this? Here's a care plan. 3 times a week for 4 weeks, twice a week for 6 weeks, once a week for 12 weeks, and there's a cost. So is this a good care plan? Well, unfortunately, this is a treatment schedule, and it kind of outlines part of a care plan, but it's only a little piece, right? A treatment schedule is not a care plan. It doesn't do what we need it to do. We need to go beyond that. This is from the OIG, who is like the police for the federal government, for federal programs, to see if there's problems in these programs in terms of spending. So they like to look at Medicare stuff, and amongst Medicare stuff, they like to look at chiropractors. Every year, basically, for the last several, they've come out with another report about chiropractors. And this one came out in 2009. And I mean, the title alone is just kind of scathing, right? Inappropriate Medicare payments for chiropractic services. So a couple of things in that report, they said, we see chiropractors have treatment plans, but they were never written down. Or I rarely saw documentation of a plan which included all the necessary elements. And so Medicare, the OIG particularly, has been under the impression that chiropractors don't do care plans, don't understand them, or ignore them. And so it's right there, straight from the source. They think we don't do it. So Medicare does have specific things in their care plan that they require. There's three elements. And I apologize if this is a different LCD from yours, but this is still the same in yours. This one's just it's identical, it's just a different one. They say there are 3 things that should be in a care plan: the level of care, the treatment goals, and objective measures to evaluate treatment effectiveness. So I'm going to capture all that, but I want to make sure I capture stuff that satisfies all payers as well. So I think that a care plan should answer these 5 questions. If you were to provide me with a care plan for one of your patients, I would want to be able to see right away why you're treating the patient, what you're going to do with the patient, how long and how often you're going to see them, what you and the patient are trying to accomplish, and how do you know when you've accomplished those goals. And I put you and the patient trying to accomplish because I want them to be patient-centered goals. If your goal is to get them to sleep 8 hours, but their goal is only 4, then that's not a very good goal. It needs to be the goal that the patient also has ownership in, right? So these are the 5 things that a care plan should tell me. So I'm going to give you an example and help you out here with care plans. There should be a diagnosis in there. And I have a whole other presentation about what a diagnostic statement is and how to create one. But basically, it's a summary of what you believe is the problem, but the way you summarize it aligns with the code descriptions. That's a diagnostic statement. In your care plan, you need to outline the specific services and procedures and the rationale. Far too often, I see notes where they say, well, here's our care plan, but it never says that they were going to do E-stim or exercises. They just are doing them, but they never explain why they're doing them or what they were going to do. And that really bugs me. This is also where you can put in the number of weeks or the number of times per week, and then the phases or stages of care. So the care plan is going to say, here's our first stage of care, we're going to do this. Here's the next stage of care, we're going to do that. And this is where you put the goals and outcomes. And long and short term, I think short-term goals might be something you put for each stage or phase and maybe specific to a certain service. Long-term goals may be what you want out of the entire episode. And I'm going to kind of shift for a second and let's see here. Talk about diagnoses for just a moment, because this is a real common question I get too. It's which diagnoses are the ones you should use? What are the best ones? Which ones go first? Well, what I've done here is I've taken the liberty of using Medicare's guidance. Let me just check one. No. Who previously and through other entities have said these diagnoses are more serious than these, and these are more serious than those. And so I've got them listed here kind of by category. I also took the ICD-10 guideline that says the most serious things go first, and I came up with this list. So I made this up, but the idea here is if you ask me which diagnosis codes should I use first or which ones are more important, this is my list in order. The most important or significant ones you should list is nerve, then acute injuries, then structural, then functional, then symptoms, then complicating factors and comorbidities, and finally external causes, which are optional. Now, as you look at this list, you might go, wait a minute, where's the subluxation diagnosis code? And if it's Medicare, it's first. That's the rule with Medicare. You do that first, followed by one of these, and then you do it third, followed by one of these, and then fifth, followed by one of these. That's how Medicare wants to see it. But if you don't have a requirement such as Medicare saying that subluxation or segmental dysfunction has to go first, then I would throw it somewhere in the middle here, like as a structural diagnosis maybe. And I would list my nerve-related disorder first because it's more serious, I think, than subluxation in terms of establishing medical necessity and ongoing care. If you're tempted to go for symptoms like pain management, I would strongly encourage you to add the phrase due to for better specificity. So if you say the patient has cervicalgia, and that's the code you want to use, don't use it unless you can't come up with anything better. If you can add due to and say cervicalgia due to something and explain the cause, that's far more powerful in conveying medical necessity. In the diagnosis, you can also list complicating factors if relevant, like diabetes. Don't imply that you're treating it, but you can certainly comment on it and explain that it complicates the case. And that's where a diagnostic statement comes in handy, where you can explain all that rather than just list the codes. You can explain the rationale behind them. When it comes to procedures in a care plan, it's really important to tie the treatments to the diagnosis. So this is another issue that I run into and that I'm seeing that payers have a problem with. If you decided you want to perform 97110, that's therapeutic exercise. Its purpose is to develop or improve strength, endurance, range of motion, and or flexibility. Okay? So if the reason you give for it is the diagnosis of cervicalgia, and I'm the payer, I'm going to say no, because 97110 is not for managing pain. It's for range of motion, flexibility, etc. But if you had a diagnosis like muscle weakness there, M6281, and 97110 is for improving strength, like I get the link. They go right together. So I'm not going to challenge you if you use a diagnosis that ties right into the procedure or service. Likewise, if you try to get reimbursed for 9943 extraspinal manipulation, but you have no extraspinal diagnoses, that's a big mistake, and you shouldn't get paid. So if you did, if you tie it to a cervical diagnosis code, it doesn't make sense, and you shouldn't get paid for that. So I'm at the top of the hour right now, and I've got through 80% of what I had intended to share with you guys. I want to pause, though, and see if we can talk about some questions, Jeff, and see if there's some other things you want to focus on. We take a few minutes and just do some Q&A.
All right. Well, thanks, Evan. Yeah. Anybody that's on, are there any questions that you had that Dr. Gwilliam didn't answer, or other comments or questions for him?
There you go. And there's a sample care plan for you to look at. Satisfied all that criteria.
Anybody have any questions or comments that you didn't get answered?
So with your software, how much of this information is just a click of the button, or is it have to be typewritten in?
So we have we call it a care plan wizard, and this is a screenshot of that. And so we have a way to capture all this information using care plan templates that you can create and then reuse later and modify. And so if you're interested in looking at that more, Jeff gave me my contact info, and I can answer some questions about the software and talk about it. But yeah, we do have a way to do that.
And with care planning, as Medicare said to you, it seems to be where we're probably most deficient. Yeah.
In fact, in one of the CERT reports from a few years back, they said, the biggest problem with a lot of chiropractic records shouldn't have been paid, and the major reason is insufficient documentation. And the most common cause of insufficient documentation, the most common problem with documentation, is the care plans are inadequate. That's the biggest documentation issue according to what Medicare thinks of us. Yeah. What else? Anything else I can help you guys with? I hope you found this to be useful.
If nobody has a question, one of the challenges we have is just this whole goal setting things with patients, they just, their goal is to get out of pain. They don't know how to come up with something. Do you have any secret tools to maybe get better goals from them?
Well, I like to use the outcome assessment tools to capture ADL-based goals. So you make them answer the OSWESTRI or the functional rating index or the neck disability index. And if they mark on there that they have trouble walking a certain distance or lifting a certain amount of weight or sleeping through the night, then you can take that answer to that question and make it one of your ADL-related goals. You want to capture, if the patient says, I have a hard time moving the laundry from the washer or the dryer, or I lean over the sink and my back hurts when I'm, those are the ones to make goals around that. And I find that, those are the goals that are the easiest to support and hardest to refute. When they are focused on ADLs and they're specific and measurable, they got a number on them, and you have a time frame when you expect to see it change. In fact, I'll go back to another slide here and show you some tips on goals. I think I got, where is it? This one. These are the best goals. Now, if you just want to say reduce pain, go ahead. I think you can do that. You want to reduce pain. Patients want their pain reduced. You want to help them with it. But that goal is not very good at helping support medical necessity. Reduce pain is way too vague and it's not measurable. But instead, you come up with how the pain affects an activity of daily living, like sleeping or walking, and then you specify information about it, you put a time frame on it. That goal can be measured and is very easy to use to defend your case. To show that the episode of care follows a journey and there's progress. Okay? That's my best tip for you on that one. Good question. Anything else?
Anybody else have questions or comments for Dr. Gwilliam? If not, Evan, thank you for your time and your expertise as always. And I will be, for everybody that's on, I will be sending out the email with the test, and it will include a PDF of Dr. Gwilliam's slides as well. All right. Well, thank you, everybody, for participating, and have a good rest of the day.
All right. Bye-bye, everybody. Thanks.